support. Happy to welcome Dr. Scott Halpern from Penn to give us some insights here. Welcome, Scott.
Thanks, Neil. Good morning, everyone. This? Okay. So I'm going to speak to you today about how institutions, hospitals, and ICUs may vary in their provision of different aspects of end-of-life care. And then I'll use the second part of the talk to explore at least one potential mechanism that may explain some of this variability, namely how physicians and other clinicians communicate with families in the intensive care unit. So, if we're going to explore variability in the provision of end-of-life care among hospitals or ICUs, we need some metrics that are relatively simple to measure across a variety of different settings. And these are three that I find somewhat useful, and we'll talk about some of the data that are available on each of these three. So, the proportion of patients who are in a hospital who are admitted to an ICU with pre-existing limitations on life support, the provision of life support in the ICU to those patients who are admitted with such limitations. And then for patients who are admitted to the ICU full code, as most are, the proportion of them for whom new decisions to limit life-sustaining therapy are made. So just to explore the first, to begin, these are data that are probably familiar to many in the audience. This was a nice study by Deb Cook and colleagues back in 2001, where they looked at among ICU variability in 15 different centers, 4 that were not in Canada and 11 that were in Canada. And using the Canadian centers as a reference standard, they assessed the proportions of patients in these centers for whom within the first 24 hours of an ICU admission, there was a new directive either to do CPR in the event of a cardiac arrest or not to do CPR in such an event. And if you look just at the first 3 centers, you see compared to the average Canadian center, one in Australia, one in Sweden, and one in the US, it's somewhat lower odds of both directives to resuscitate and directives not to resuscitate. And then the 4th center I'm listing is also from the US with considerably higher odds in that one center. They subsequently looked at variability among the 11 Canadian centers, and using what's called Center 15 as the reference standard here, again, you can see variable odds in the likelihood of such directives ranging from about half the odds to more than 4 times the odds of such directives, again, within the first 24 hours of an ICU admission. These are some data from our group looking at variability in the United States. And this is a complex slide. Let me walk you through it. So what we've done here is plotted 105 hospitals in the United States that are available in the Project Impact database. And we've looked at the proportion of patients in those hospitals who are admitted, among all who are admitted to ICU, the proportions who have pre-existing limitations on care. This could be a simple do not resuscitate. It could be an order to withhold some other form of life-sustaining therapy. It could even be an order for full comfort care. And these data, so on the y-axis are each of the 105 hospitals, and on the x-axis you see the proportions of patients. And you can see considerable variability from fewer than 1% to 12% and even more in the case of a couple outliers of such patients. Overall, it was approximately 5% of patients in these 105 hospitals. Now you say, well, different hospitals are admitting different patients, and indeed they are, and that could explain some of the variability, but these are predicted probabilities, meaning that they're adjusted for more than 30 patient factors, and that patient factor model actually discriminates with greater than 90% accuracy who will or who will not be admitted with a decision to limit life support. So I think this is a pretty substantial variability that is attributable to the institutions in some way. So how about the provision of life support to patients who are then admitted among those who have pre-existing limitations? And here you see a similar plot. So now we've restricted the data set just to those 13,000 patients, or the 5% who were admitted to such limitations, and we've plotted the proportions at each of those hospitals who newly received mechanical ventilation, newly received dialysis, or newly received vasoactive infusions. And again, you can see considerable variability across the ICUs in this setting, from approximately 12% to almost 80% of such patients. And then finally, how about what do we know about variability in new decisions to forego life support once patients are in the ICU? So here you can see ICUs plotted. This is about 270,000 patients admitted to 150 ICUs in the US. Again, each ICU is one dot with the predicted 95% confidence band. And you can see considerable variability once again, from about 6% or so to upwards of 20%. Of patients with new decisions to limit life support. These are among patients who are full code at the time of their ICU admission. You say, well, you already told me that the patient-level model explains 90% of this variability, so we should be comparing apples to apples in this setting, but there could be some residual confounding here going on by different patient populations in the different hospitals. So in an effort to try and make the patients look even more similar, we restrict now to only those patients who've been on mechanical ventilation for at least 4 days or longer, and even among this population, you still see the dramatic range of variability among intensive care units. Now, the entire curve here is shifted to the right, of course, because these are sicker patients. They've been on the vent for 4 days or more. So you would expect there to be more limitations on life support, and in fact, that's what you see. But the point of the slide is that the variability among ICUs in presumably similar patients is quite dramatic. So what might explain some of this? As I mentioned, I'd like to focus a little bit on physician communication and physician-level factors. So I've been talking about variability among institutions, but how about variability within an institution? This is one of my favorite studies by Alan Garland that was done when he was at Case Western, where they looked just at 9 ICU docs who were in the Case Western ICU over a 4-year period. Now, over a 4-year period, you'd imagine that each of these 9 intensivists were seeing presumably similar patients. And yet, there were dramatic differences among those 9 physicians in the proportions of their patients who received new decisions to limit life support and when those decisions were made. So if you just look at sort of 100 hours or after about 4 days in the ICU, you can see 7 of the physicians have made new decisions to limit life support for somewhere between 20 and 40% of their patients. And then there are 2 physicians down towards the bottom here where the rates are considerably lower, on the order of 3 to 5%. So why might that be? Why do physicians differ in these rates so dramatically? Well, here's one study that was done in San Francisco where they audio recorded 72 family meetings with very seriously ill patients. And in fact, these patients were so sick that 72% of them died in the hospital. And yet, even among this very, very sick population, the physician only offered the option of comfort care about half the time. And when the authors looked to try and understand what was it about the patient that explained or contributed or was associated with the odds of such an option being offered to the family, they couldn't find anything. There was nothing about the patient's severity of illness, their stay in the ICU, its duration. The only thing they found that was associated with the odds of offering comfort-oriented care was the strength of the physician's belief that comfort-oriented care was the right thing. Here's another study a little bit more recently. This is a mailed survey of 600 or so ICU docs in the US. And they provided these physicians with vignettes about essentially a standardized patient and asked them a variety of questions about how they would communicate with such a patient. This is just one example where they asked, how often, if at all, would you provide a specific recommendation about whether to continue life support for patients like this? And you can see that about 20% said they would always do it for such a patient, but about 12% said they rarely or never would do it, and the remainder were somewhere in between. So again, considerable variability here, and 2 out of 5 ICU physicians, in fact, reported that providing recommendations was only appropriate when it was requested by the surrogates. And this kind of contravenes what we know about most surrogates or patients' preferences for shared decision-making. So this is a nice study from Doug White's group where they looked at two different, very different types of decisions. So antibiotic use, so not a value-laden decision, a sort of a strict medical decision. And as you can see, most patients, or surrogates in this case, would want the physician making those decisions for the most part. These are the bars shown in black. But even for value-laden decisions, such as the use of life-sustaining therapy, surrogates typically want their physicians at least involved. So you can see that the bulk of patients are in categories 2 or 3, where the surrogate either wants to make the final decision after they've received a recommendation, or in fact they want to share in that decision-making responsibility equally. There are very few in category 1 where they basically want to make such decisions left to themselves. So let me just describe a patient I cared for in the ICU at Penn about a year ago. We called him Big Nat, and he was a 60-year-old that may be familiar to many of you. He had refractory leukemia. He was at Penn for a second, if maybe a third opinion at this point about treatment options. He had a big family that was at the bedside 24 hours a day. He had come in with septic shock in the setting of pancytopenia, and after about 60 hours of markedly aggressive life-sustaining efforts, he was on virtually every form of life support we knew how to provide. 3 vasopressors, he had developed anuric renal failure, still requiring high levels of ventilatory support, and of course, he was not in a position to be making too many decisions. So just think about how you could foreseeably anticipate a cardiac arrest for such a patient. So let's suppose you chose to discuss CPR with the family at this time. So for this patient, how might you broach that conversation? So one option is to say, well, in situations like this, there's a risk that his heart may stop. If it did, would he want us to do chest compressions to try and restart it? And I'd like you to think about how many of you would use an approach like this. Or perhaps you might use an approach like this. In situations like this, there's a risk that his heart may stop. And if it did, our natural response as critical care doctors would be to do chest compressions to try and restart it. Is that what he would want? Or a third approach. In situations like this, there's a risk that his heart may stop. And if it did, we would not routinely do chest compressions because they'd be unlikely to restart his heart in this situation. Does this seem reasonable? So how many of you would choose option A or something similar to option A? How many would choose option B or something similar? Very few. And option C? Okay, the vast majority. So the point of this exercise is not to recommend one specific strategy to you. The point is to relay that there are physicians. This is a particularly one-sided crowd, and actually your biases accord with my own, so I'm pleased to see that. But there is certainly dramatic variability among ICU physicians in how they have these types of conversations. All 3 of these approaches maintain choice. The surrogates could choose to have resuscitation or not in any of the situations. But as you could all imagine, they would dramatically influence the choices that would be made. We don't know much about this empirically in the ICU setting, but this is one nice study from Amber Barnato and Bob Arnold at the University of Pittsburgh, where they did a simulation. They videoed an intensive care doctor and provided this video simulation that with a few specific tweaks to patients who identified, or people who identified as being surrogate decision makers. And among the several different tweaks, in some cases the physician said, people have different thoughts on this, but in my experience most people want CPR. And in some cases the physician said, people have different thoughts on this, but in my experience most people do not want CPR. And that simple tweak led to substantive differences in the proportion of surrogates who chose CPR from 64% down to 48%. So again, just this is the extent of the data we have. We have lots of data about the influence of framing effects on different types of decisions, some in advanced care planning, for example, but this is about as close as we can come right now to these effects in the ICU setting. So in summary, I would say that there's considerable among ICU and among provider variability variability in end-of-life communication, that our communication styles and something probably endemic to the ICU, its culture, contribute to the aggressiveness of care that's provided to seriously ill patients. And finally, I think, we can identify how different communication strategies may influence choices, but where we really need to take the work is to identify how different communication strategies influence outcomes after those choices are made, including, I think, issues of surrogate bereavement following the death of their loved one. Thanks.
Thanks very much, Scott. We have some time for questions if anybody would like to take advantage. Let me ask you, Scott, while we're waiting for folks. The last point you made about not just looking at the quality or the decision to limit life support, but how it's communicated and the effects afterwards. I think that strikes me as a very important point. Really, that we should be including. We have after ICU clinics for ICU survivors. We don't have after ICU clinics for families of patients who die. How do we reach out to them?
Yeah, I think it's a great question, Neil. I don't know the answer with any degree of certainty, of course, because it hasn't been studied to my knowledge, but I think it's a ripe opportunity for some new scholarship around, what forms of post-ICU bereavement counseling can actually be beneficial. We hear in our ICU a lot that, one of the reasons that we should enroll our patients in the U.S. we have hospice care, which is a bundle of services that are available to patients and their families near the time of their death and even after death that provides bereavement counseling. And we're often encouraged to enroll our patients in hospice care for a variety of reasons, but one of the reasons that's promoted is that then the families can have access to these bereavement services. But there's never been an evaluation about the utility of these bereavement services, how they should be structured, the timing with which they should be initiated, for how long they should go, what forms of communication should be embedded within them. So I think there's tremendous opportunity to get smarter about that. Ellie.
Thank you, Scott, for the great talk. I have a very small frustration and one question. The frustration is about the option D, because I didn't raise my hand, because I didn't find my way there. Maybe one option for this patient would say, if he's in cardiac arrest, he will die, with or without CPR.
Yeah.
So I think that we are also committed to provide prognostic information, and it's clear it would be another option, and maybe the one I would choose. Another thing is about, it's complicated. It's very complicated at the bedside to manage end-of-life care and to make decisions. And what about thinking on making and improving our ability to make all the other decisions of non-end-of-life care? And for example, we should better explain to the nurses, better discuss with the fellows, the residents, about those patients who are in a full code status. And then I think for them it will be easier and it will be obvious for them that for other patients we need to shift to comfort because the situations are very different. And what we do on a daily basis when we round, we are focusing attention on those patients who are dying and thinking that it's normal and we behave normally by providing everything to the other patients.
Yeah.
But I think that if we are reinforcing the amount of things, of information, communication, and everything that is also done in non-dying patients, it will be, I think, easier for clinicians to cope with these very complicated decisions.
Great. Excellent points, Ellie. Maybe just to the first point, I'd say that your option D is a perfectly reasonable one. I think many would choose it. In fact, it highlights that of the three that I provided, there are actually many more ways, and those additional ways could introduce some additional variability. With regard to what's happening to the totality of patients in the ICU at one time and our tendency to focus our thinking or focus our efforts on certain subgroups, I think that's also a neat area for further scholarship. How decisions made for some patients alter our capacity to make decisions is like a skeletal muscle. It's fatigable. And if we make these very difficult, taxing decisions for certain patients, our internal reserve for engaging in those conversations with other families may be depleted, and how can we sort of overcome those sort of human factors within ourselves to provide the best care for all patients in the unit.
And last question, Sam.
Hi, Sam Shemy from McGill. Thanks for your talk. Just a question about, it's well known that physician factors have a profound impact on end-of-life care decision-making in the ICU, physician rather than patient care factors. And I just want to ask your opinion on whether you think that is related to divergent perspectives depending on the type of physician and who they are, or whether it's really fundamentally related to our inability to prognosticate reliably in many of the situations in which we make decisions on.
Yeah.
And to distinguish the physiological futility of I cannot sustain circulation versus the true qualitative issues that many of us face.
Yeah, so I guess I would answer your question by just saying yes. I think it's both of those. I think the second is particularly interesting in the sense that there's sort of two types of uncertainty that we have to grapple with. What I would call first-degree uncertainty or first-order uncertainty, which is, we don't know whether the patient could survive their ICU stay or not. There's some probability between 0 and 100%, and if it's not 0 and if it's not 100, then we have some degree of hesitation. I think most of us sort of can get past that first order uncertainty, but where we really struggle is with what I would call second order uncertainty, which is that even if we say that it's a 99% chance of a given outcome, there's some confidence interval around that. And different clinicians may have different comfort levels with that degree of ambiguity around our prognostic judgments. So I do think it's challenging, and that may indeed explain some of the variability as well. Thanks very much.
Thanks very much, Scott. Now it's my pleasure to introduce Dr. Rob Fowler, who's Associate Professor of Medicine and in the Department of Critical Care Medicine at Sunnybrook. He's done a lot of work in the end-of-life field and is going to share some thoughts and data with us about how Canadians die.
Great, thanks very much, Neil. I'll try to combine a little bit of the local Canadian perspective, Ontario perspective, and talk about some of the variability that Scott addressed, even within our own context. And maybe we'll lead into Ellie's talk around international variation. I have a couple of financial relationships based upon funders for the work that is going to be presented, so I want to thank them. And I have a personal conflict of interest. Based upon the largest ongoing cohort study, it's a very high likelihood that I will die, as of most people. There's debate about 1 or 2 people in resurrection, not, but for the most part, everyone has met the same outcome. So this is a clinical vignette to start. So a 40-year-old man, father of young children, intelligent, professionally successful, had metastatic thymus cancer. He had exhausted all oncology treatments and protocols. He presented to the emergency room at our hospital with respiratory failure. The etiology was likely secondary to progressive cancer. It's always a bit uncertain if there could be a reversible infectious overlay. He had large pleural effusions. He had parenchymal disease in his lungs, and his phrenic nerves on CT scan and subsequent MRI were encased, in fact, with tumor, and he suffered ventilatory failure in addition to hypoxia. He was severely cachectic, and he looked like a patient that was at the end with cancer that clearly was going to die as we consulted on the patient. I'm going to put that just in the background for some of the context of the talk, and maybe we'll come back to it. As Lisa mentioned, there is this so-called silver tsunami happening, and it's occurring in many countries around the world, not all clearly, where the proportion of our population that's older is growing, and that will lead both in terms of an increased proportion and absolute number of patients that are going through the dying experience. We know that we often don't do very well when we try to grade ourselves on providing end-of-life care currently. Often we don't match care with what patients at least say they wish ahead of time. Currently, most patients who are admitted to hospitals receive very technology-laden end-of-life care to greater or lesser degrees. So what is it that kills people in Canada? So just a little bit of data here from national references. It's very age dependent, of course, so at younger ages, people are typically dying of traumatic injury, external causes. Through the middle parts of life, people will have an increasing likelihood of death through cancer, different malignancies. And at the end of life, certainly at older ages, typically now in Canada, people are dying mostly of circulatory deaths with cancer in a minority, respiratory disease, and other causes. So these are the sort of spectrum of things. This is different from 3, 4, 5 decades ago when a lot of, I would say, public awareness around things we can do to treat illnesses at the end of life was really getting going, both in the United States and in Canada, and I think it carries on today. So what do we know of the usual Canadian end-of-life care experience? So this is a slide that isn't mine. It's one that I really appreciate because it tries to model different trajectories that we might think about as end-of-life care experiences. So in the top left-hand corner, sudden death, which I think a lot of us think about probably when we were going into critical care training as clinicians, nurses and doctors and respiratory therapists. We thought of saving people that had, just had a big MI or maybe a PE or some other catastrophic sudden thing that we could intervene upon. Terminal illness, so the patients that have cancer, we might take for an example, where they are doing okay and then have a death that's accelerated. Organ failure, maybe COPD or CHF in the bottom left, and then frailty, maybe a euphemism, sort of reflected in old age descriptions of past that still happens, but happens maybe less commonly, maybe it will happen more commonly in the future. Now, how often do each of these occur? Anyone want to make a guess as to which of these four what might be the most common? Who would say sudden death, terminal illness, organ failure, most hands, and frailty? Quite a few. So I'll highlight here that it's about a split among three of these categories into almost thirds. However, the one that I think most people associate with the fix in critical care, sudden death, is in the distinct minority. Certainly these days it is. So well under 5% of our population dies of such sudden causes. We know, however, that our therapies, even though it's reasonable in out-of-hospital patients, maybe those with a rhythm or circulatory problem that can be fixed, to apply CPR, oftentimes in hospital the therapy is quite ineffective and it depends upon the patient population. So among all patients in our hospitals, maybe we could expect 15% to be discharged from hospital alive after CPR. Those without a shockable rhythm, the percentage goes down. Those that are old or have advanced disease, maybe pre-existing, survival is not good at all. In the ICU, it's difficult to know this because we often don't code it well. We often don't call codes that are showing up anywhere in databases, but the survival is probably well under 3% in terms of hospital discharge. Now, the CPR business came about in the 50s and 60s and was tried a bit before, but became popularized as a way to stave off death, to prevent it, in fact. And in large degree, the things that were killing people in the 50s and 60s were a bit different than they are right now. A lot more circulatory large MIs were occurring, and this became a very popular way to avoid death, at least in the public's mind. In the public's mind today, this was a research project that I so would have loved to have when I was a resident. So this was watching television shows and counting how frequently people survived after getting CPR, after having something bad happen to them. If you watched, I guess, George Clooney in those days in ER, about 68% of people were saved by him. Chicago Hope, I guess very, very close by to the Cook County sites, 64%. Rescue 911, the paramedics save everybody on television, for an average of about 3/4 of people surviving after getting CPR. And this is what, frankly, people see, right? This is the information, this is the medical literature, the evidence base that presents to the population that then presents to us in terms of expectations and hopes in the intensive care unit. So where is it that Canadians die these days? We've alluded to a little bit of that, and I'll try to, again, present some national data. So if we look at the western side of the country, we see that in-hospital deaths are quite common, depending upon the province, there is some variability, but in the 40–50% range of Canadians in the West are dying in the hospital. Varying degrees of capabilities for out-of-hospital deaths with home hospice palliative care. If you grew up in the eastern half of the country, where I did before going to medical school, where Lisa practices now, it's interesting that even a greater proportion of people are dying in the hospital, and I'm not surprised by this. And there are probably system issues that relate to these numbers. So 60–70% of people in some provinces are dying in a hospital setting, despite people when asked saying, about 70% of them, that they would prefer to have an out-of-hospital death, at least in their mind before they're faced with it. So what are we doing in Ontario? I'm going to present a little bit of data that compares the Ontario context as representative of Canada, may or may not be, but it's a population about a third of the country, just under. And I'm going to compare that to our neighbors to the south, to Scott's experience in the United States, because we always like to compare ourselves to the United States. Usually we look okay. The last week or two locally we haven't looked that good. The patient population that we'll look at are all deaths in the province of Ontario going back to 2004. And we're going to look at different time points, mostly though in the more terminal aspects, about 6 months ahead of death, using a variety of administrative data sources that we have available to us. And we're going to compare using the same methodologies that is done with the Dartmouth Atlas of Healthcare in the United States that captures all Medicare patients and describes how it is that they die. Same patients, same kind of metrics. These details are probably important, but not so relevant for the next few slides. I'll highlight, though, that this goes back a different time course for the US versus Canada. We're waiting some data in the US to bring it up to 2011-12. But it will describe about 260,000 patients in Canada, over 4 million in the United States. In particular, we're focusing on a group that have some kind of chronic disease condition that you can identify by coding in administrative databases to get similar patient populations as much as we can. Those that are over 65 years of age, truncated just under 100 years of age. First slide. So proportion of deaths occurring in the hospital. Now we've seen some other examples, a little bit older data than this, but in Ontario right now, over 50% of patients are dying in hospital settings. Contrast this to the United States experience, and Scott alluded to a capability for out-of-hospital death, hospice care, that frankly doesn't exist in the Canadian context to anywhere near the same degree in terms of funding and capabilities to provide an out-of-hospital death with symptom control that there are in other jurisdictions. These are not subtle differences. These are enormous differences in locations of death between two countries side by side. And it speaks to a number of things, but I think in large part it speaks to a very different evolution of a healthcare system in Canada, one that's very deep, but also very narrow in that we provide care in hospitals, it's covered. Outside of hospitals, difficult. We all know that in trying to get patients out of hospital to provide them with appropriate end-of-life care. Hospital days during the last 6 months of life. So I might think, well, maybe it's not so different there. Maybe we don't admit people into hospital quite as frequently. Again, in Canada, much more common to be admitted to hospital many more days over the last 6 months of life than it is in the United States. Things that intuitively to me probably were in the other direction before looking at the data. A marker of quality of care, and it's debated whether this is in fact good or indifferent quality, might be the number of physicians that are seen in the last 6 months of life. This is a metric that has been used in the United States, so the proportion of patients that would see more than 10 individual physicians in the last 6 months of life. So in the US context, about 35% might see more than 10. In the Canadian context, over 3/4 of patients will be moved to one doctor or another in different care settings as inpatients or outpatients over the course of the last 6 months of life. So how about the intensive care unit where we all work? How common is that a therapy that we administer? Representative patient, I guess, for those that might be coming from an ICU this morning. Comparing the US to Canada, we know that we have a differential capacity to deliver this care. Many more ICU beds in the United States context. Depends on how you classify it, but a nice study by Hannah Wunsch characterizing different countries' capacity would peg Canada and the US as quite different. So about 20 ICU beds per 100,000 patient population, about somewhere in the ballpark of 10 to 13 in the Canadian context, not out of line with a lot of Western Europe, Australia, etc. In our hospitals, occupancy is quite different in the US. Often, occupancy is very high. This is a slide from the Ontario context. The arrow in the circle represents the hospital where I work, where occupancy is not unusually at about 100%, oftentimes a bit more, hard to code the extra patients in the hospital in the emergency room, but we're running full pretty much all the time. Different in the US, where there is often some residual capacity to admit patients. So greater capacity to admit patients, greater number of ICU beds. The differences here, however, are not so great. So the US, in fact, as we would code them, does more frequently admit patients to hospital the last 6 months of life than we do in Canada, but the differences are not strong. Certainly not the magnitude that we saw in the other slides. And this is, again, speaking with a much greater capacity to do so in the US. The differences are only marginally higher. How about costs of care at the end of life? This is always something that we speak about, often not directly at the patient bedside, but sort of in a bit of hushed tones, and certainly health ministries are interested in this, hospitals are interested in this. Healthcare spending goes up as we age. That's a given, I would say. Happens in most all jurisdictions. If we look at global healthcare spending, because we're making US and Canada comparisons, Canada usually sits in the middle of the pack of Western European nations and Australia, spending about 10-11% of the GDP on healthcare. The United States is an outlier, spends more, upwards of 18% now on healthcare, and this is something we've recognized for a long time. To break down the exact kinds of costs, however, if you look at the United States and Canada in comparison, the public spending is not that dissimilar. About $3,300 in Canada, just under $4,000 in the US, looking at per capita healthcare spending. The differences seem to be more in private spending and out-of-pocket spending. That's often difficult to capture. Total, lots more spending in the United States. If we look at Medicare spending, so from patients in the United States that are of the same age group, Medicare accounts for about 98% of costs that are recovered from insurers in the United States for this patient population. You compare the same patient population in the United States. In 2004, starting out the study, there was a significant difference. Canada has certainly gone up with respect to end-of-life care spending, not in a straight line, but escalated over the last part of the 2000s, and we'll soon see if we've caught up or not to the United States. But spending definitely increasing over time. A couple more slides. So what do our patients want and how do we respond? A study that was published just this past year by Darren Hyland and colleagues. I'll just highlight a few things. Only 12% of patients in this hospitalized cohort at a high risk of death preferred life-prolonging care. Interesting that a lot have talked about this with respect to other people in their circle of care, their family. 3/4 had named a substitute decision maker, but only about half had discussed it with any healthcare professional. And when they looked at agreement with what patients actually wanted and what was in the chart, there was agreement just about 30% of the time. At our own hospital, we tried to look at this issue. Where is it that people are dying and how satisfied are they with the care they're receiving? And we have about 1,000 deaths annually in our hospital. And we surveyed just under a third of them with a couple of different tools and asked them a number of questions, one being, in general, how satisfied are you with the quality of life, the quality of care you received at the end of life? Asking substitute decision makers to fill this out on behalf of patients after death. We found that in terms of where people died, in terms of their preferred location, about half died where they were thought to have wanted to die, and about half didn't Most commonly, that was in the intensive care unit. Most would have preferred an out-of-hospital death if they didn't die where they said they wanted to. And we found, in fact, that if a patient died in their preferred location, as specified by the SDM, they were 18 times more likely to perceive satisfaction with end-of-life care in the hospital. Why is there a mismatch between stated preferences and care delivery? I think it's sort of a lot of reasons, and I'll just mention a couple before closing. We certainly have evolved a system at the population level to provide care that is very rich in the hospital, difficult outside of the hospital setting. Patients and families soon grow to appreciate that despite their prior wishes when they're in the system and are struggling to get the care that they need. In the hospital, we provide typically one-to-one care in the intensive care unit in Canada. Patient-to-nurse ratios on the ward are much different, and the palliative care resources we have are typically, I would say, inadequate. We know that by the number of patients that wait on admission lists to palliative care wards while they die in the hospital. We, I think, deliver very different messages to patients and patients leading up to death than we would like. In this really neat study in the New England Journal over a year ago, 69% of patients with lung cancer and 81% of those with colorectal cancer did not report understanding that chemotherapy was not at all likely to cure their cancer. That's concerning. More interesting, and maybe more concerning, is that the risk of reporting inaccurate beliefs about chemotherapy was higher among patients who rated their communication with their physician very favorably, implying that patients perceive physicians as better communicators when they convey a much more optimistic sense of chemotherapy in this case. I think it gets broader than this, though, in our society these days, and this goes back to a proclaimed war on cancer, specifically in the United States, that has spillover across the world and has really been taken up as slogans and the way we approach death, and I think what we sell collectively, not as ICU doctors so much, but as a profession generally, to the population, that cancer can be beaten. We can defy death in heart disease. We can even thank our donors for helping make death wait. And I think that if we want to change our system, some of the change will come from our own work, but it certainly is going to be much broader than that at a societal context and at a messaging context. And I think people are energized to start that process, but we have a long way to go to change some of the numbers on the slides. Thanks very much.
Thank you, Rob. That was excellent. We have time for questions. While people are coming to the microphone, perhaps I'll just start by asking, when you're drawing comparisons between the amounts of health care that are provided at the end of life, United States versus Canada, or between regions in Canada, I guess one of the challenges, and I just want to hear your thoughts about this, is that how do you determine when more treatments at the end of life might just reflect that we're trying harder to save someone when we don't know that they're going to die yet? I guess we're always looking at these data in hindsight, and in I think many of these cases we don't know that they're going to die until we're well into it. So perhaps you can comment on that.
Yeah, you're right, and there's always going to be that uncertainty that will lead us down different diagnostic and therapeutic strategies that ultimately we might say were examples of non-beneficial care or potentially inefficient or ineffective care. So I think there's a component that we will never be able to remove from resource use, spending, et cetera, possibly care that we ideally would not deliver if we had have known they were going to die. And so at a very qualitative level, I guess I might answer that there's probably a large proportion of patients, however, that we do think has a very high likelihood of death, and that we could probably identify those. Again, if I go back to the vignette, the very sort of clear example, that patient ended up coming to our ICU, was ventilated in the intensive care unit for months, struggled with end-of-life care, planning for the patient, even though the healthcare team and in fact the family knew that the patient was going to die. So I think you're right, we'll never be able to reduce it to perfection, but I think probably qualitatively there's a large proportion of patients that we probably can identify and save in provision of care.
maybe start by introducing yourself, James Downer.
Hi, James Downer from Toronto. Hi, Rob. Thank you very much for that great talk. I want to integrate a question across two talks here with Scott's and yours. So Scott talked a little bit about the default and the power of the default in terms of how things are presented. Critical care and aggressive care is the default in our pathway, and I think part of going towards a less aggressive end-of-life care pathway involves making an active decision to deviate from the default. And I wonder we're all familiar with the concept that particularly when you're in a high-stakes environment, people tend to freeze, right? So it's the deer in the headlights or the driver skidding on ice. You kind of freeze and don't do nothing and plow straight into the car in front of you. I'm wondering how, if you could speculate on some ideas about how we as a profession, how we as a society can maybe work towards, with that understanding, how do we present end-of-life care in a different light as not something that is the sort of alternate option, but perhaps probably the default option?
Yeah, I mean, James is is an expert in this area as a palliative care doctor and critical care physician, and probably does this, better than most any of us in the room. In terms of the spectrum of potential fixes for this, again, I do think that it seems as though we are at a point that the profession, critical care, more broadly in the medical system, has passed the threshold, the tipping point, if you want, for the notion that this is an issue that we have to address, as opposed to an underlying sort of grumbling, murmured concern. And I do think that it's going to require, again, a very broad approach across the profession and across the population. Public engagement that we've seen in the United States recently with the IHI and the Conversations program that they have. In Canada, a similar public awareness that we must think about this as an inevitable course of life, and we should improve our ability to talk about it as a population, to normalize death again, if we can ever do that. And then the issue of advanced care planning, it's easy for us as ICU doctors to say, we've got to look way upstream and put this on the shoulders of family care doctors, on specialists that care for chronic illnesses, who are increasingly, I would say, uncomfortable with the process, and increasingly maybe don't view it as their role. But in the Ontario context and other places, the OMA president this year has put out there as his agenda item number one to help our population of doctors do advanced care planning a bit better. And so that's a process the OMA is engaged in. The province and Health Quality Ontario is similarly engaged in a process to say, what's the evidence to underlie some system change? At the local level in our ICUs, Scott alluded to this, I think there are huge things that we can do to improve upon with framing in our conversations with patients and families that are very influential, again, as Scott has demonstrated so clearly in other research, that we are able to direct patients in the right way much more commonly if we use the right language.
Let's take one more brief question with a brief answer.
Hi, I'm Valerie Schultz, palliative care physician, practice exclusively in the intensive care unit in London, Ontario. Thank you very much for this lectures. I listened to Hannah Wunsch, I hope I'm saying her last name correctly, talk about de-adoption and the concept of advanced care planning, and today with James. And what I'm wondering about is not so much just the advanced care planning, but the alternate care pathways that need to be created in our society for people to actually have care as they're approaching the end of their life. It's not just enough to decide they don't want ICU, it's what is the alternate care pathway. And I'm wondering if there's an opportunity for ICU to collaborate with palliative care to create and advocate for pathways that are funded by our healthcare system, since palliative care is outside. It's in long-term care as opposed to in our healthcare.
That's a terrific invitation, and I think absolutely that's a great way forward. I do think we need alternate pathways because patients are choosing among the only pathway they have now to provide intensive care at the end of life. That's right.
It'd be good to collaborate on it.
Thanks very much, Rob.
Thanks. Our final speaker for this session is Dr. Elie Azoulay. Dr. Azoulay comes to us from Paris, where he's a professor of medicine at the University of Sorbonne, and he is also the editor-in-chief of the journal Intensive Care Medicine. He's published extensively on improving end-of-life care and also communication. Today he's going to speak to us about a global view around providing end-of-life care. Thank you, Eli.
Thank you very much. Thanks again for the invitation. I'm very happy to be with you. And just to provide some global perspective on the available literature in ICU end-of-life care. So these are the global data, and we are now more than 20 years after the first description by Dr. Smadira about withholding and withdrawing life-sustaining therapies in the ICUs. And we know from that period that there were some benchmarking criteria. For example, having CPR in the ICU was believed to be a non-beneficial care, and this had been measured in different ICUs. And these are the data from Charlie Sprung, published in the JAMA 10 years ago, where there were some comparisons across different countries in Europe. And as you can see, in Southern Europe, withholding life-sustaining therapy is very much less than in Northern Europe, and withdrawal life-sustaining therapy in South Europe is very rare, where if you are going to Northern Europe, you have more the pictures like in North America. And the active shortening of the dying process that is quite forbidden by law in most of these countries, and it was the case at that time, was still very rare. But if we are going to see what about hospital mortality in these patients, we were aware that some of the patients for whom we were withholding life-sustaining therapies, some of them survived, but in case of withdrawal, it was very different. This was another comparative studies in several European countries, and there were very significant differences in the proportion of patients dying after an end-of-life decision, in the time from admission to end-of-life decision, and this is of course related to the type of patients we admit. If we are admit only full-cut patients, then we have very few end-of-life care in the ICU, and if we are admitting patients with intermediate goals of care, so of course DNI, DNR, and many other patients who are very sick, so we will have more end-of-life decisions. And of course, in some countries, like in France, it's very rare that an ICU patient who has just been extubated after a terminal extubation will be discharged from the ICU, because there is nowhere in the hospital some structure that can care for him, and the integrative palliative care system that has been described by Dr. Nelson quite doesn't exist in most European countries. So if we are going into larger descriptions, we can see that the proportions of patients dying after a decision to withdraw life-sustaining therapies is very different, but also the relationship with family members are different. And this was declarative at that time, and you could see that in Spain, Italy, and France, maybe we are less honest with family members, not providing at that time all the information, and this was the baseline data on which we worked to improve end-of-life decision-making in the ICU. Another thing that is very different based on the literature and on the studies that have surveyed ICU nurses and the end of life is how much an ICU nurse is able to initiate an end-of-life discussion, which is very rare in South Europe and very more frequent in North Europe, I guess as much as here in North America. So these were the global data. They were not made for benchmarking, and we could not say that we used quality markers to compare across different countries and different ICUs, and the information on variability is obvious, but we know the numbers, but we don't know the why and the how. Looking at detailed data, there is something that is very clear. You can be parentalist, you can be more into the autonomy model, but overall, you are not the same from one day to another, and we are ourselves very much variable. And this is a very nice paper showing that you can very much change your patient's decision according to how you're going to provide some information. We are here dealing with patients with intractable lung cancer, and there is quite an equivalent in terms of long-term outcomes between radiation therapy and surgery. And you have two framing. One is the survival framing. You are going to avoid saying mortality. You only saying survival. So surgery, if you are operating 100 patients, 90 will be alive after the perioperative period, 68 after 1 year, and 34 after 5 years. Radiation is almost the same result, but you never say dying. Now you are having the mortality framing, and you don't say that patients are going to live. You say that they are going to die. 100 patients operated, 10 are going to die, 32 after 1 year, 63 after 5 years, and the same for radiation. And of course, the choices for radiation therapy in the mortality framing are very much different. So we can be where we want to be, but according to what we say and the scenario and the framing that we use to provide information and to assist patients in their decision-making process, we are providing very, very different outcomes. So we need to be aware that sometimes in patients, but mostly in the ICU, in family members, we are not having with us people who are able to make a decision on their own. And overall, in all the literature, in the US, in Canada, in France, in many European countries, the model where the family members make the decision on their own is still marginal, and we cannot consider that this is the major model. The major model is the shared decision-making model, and the shared decision-making model relies on one thing, is our ability to pass from information to communication. Information is very factual. I love you, this is information. But then if you want to communicate, you need to say, well, you're a wonderful person. I am having a great time with you. And this is why all the time I see you, I'm very happy and I love you. But the thing is that, you know, the number of times you hear I love you is very small. But the reasons why people are happy is that we took time to try to pass to them our feeling, and that we are assisting them in the process of making a decision, not making the decision by ourselves, but we know that we are influencing the decision, but we are giving them the capability, the power of making the decision, and we are committed to do so. We are not committed to make the decision, we are committed to empower family members to make the decision. This is a slide from Deb Cook comparing two studies where you can see that in both Canada and France, we are more into the mutual model, the shared decision-making model. We know that it's quite complicated, and Doug White did wonderful work at trying to analyze why people were very reluctant, and I will provide some information in my last slides. But overall, we are in a model that is a shared decision-making model, and this model is now the predominant one. We are here in the United States, and this very nice study published in Annals of Internal Medicine by Doug White. At the time he was with Randy Curtis. He was in San Francisco at that time. And they have identified 10 markers that qualify a decision. If you have 10 on 10, this is a pure autonomous decision. You are really into the perfect shared decision-making model. But actually, you can see that the number of items in 52 patients with decisions, it's very low. And overall, the median is that we are only fulfilling one case of pure decision-making model in only 2% of the cases. And because many reasons. Because the family members sometimes are not willing to take part of the decisions, because they are not able to take part of the decisions, because in 10 to 15% of the cases, there is no family member. You don't have an identified surrogate decision maker, which is a great problem. And for various reasons, we are then in a model where we are making what we can make, and in most of the time, we are not in the pure decision-making, shared decision-making model. So we need to admit that ourselves, from one day to another, we may move with an intrusive family interest to a pure family interest, depending on how is the family, in which case which case we are facing, and how we are ourselves. If we are in a model where we have had 5 deaths in the ICU the week before, or if we are taking time to provide support to a family member in a very complicated decision where a patient's preferences and values are much more important than the medical aspects themselves. So this is what I just said to Scott. We need to understand that the variability has many reasons for that. And I'm sure that if we were doing a study in one day, for example, we were capturing information on all our dying patients in the ICUs, a multinational study, we could maybe present this next year at the CCCF. It's very clear. I'm sure that we are the same in different contexts, with different family members, with different patients. And sometimes ourselves, we are different from one week to another. And this is why in any database you are going to, if you are trying to understand the risk factors for mortality, put in your model the end-of-life decision, the decision to forego life-sustaining therapies. It will be always associated with death because you are not able to adjust on a context. The database is not including any information on a context. It needs to be captured and it needs to be included on a day-to-day basis. So clearly, just to provide you with one information, we have compared the end-of-life decision-making process in patients spending their birthday in the ICU compared to other patients. So when the birth date was inside the ICU stay, we were her case, and we matched the patients to other patients not spending their birthday in the ICU. And of course, we were delaying the end-of-life decisions only because we were providing patients with a birthday present and because family members were making so much pressure and the nurses. And we were very surprised because in this study, we have asked clinicians about did they know that the patient had his birthday in the ICU, and doctors knew that in less than 20% of the cases, but nurses in 65% of the cases, because nurses are more in the room, they are more interactive with family members, not only in global information, but also sometimes with personal information. So, am I parentalist? I don't know. Certainly in some instances, but just to provide you one result that has changed a lot, not our view or our behaviors, but our ability to include family members in the decision-making process. So you have 4 boxes and 2 parts in this slide. Please look at the left part of the slide. You have 2 boxes, one white and one gray. And you can see that measuring PTSD-related symptoms by the impact of event scale, you have high scores in family members of patients who died, and this is bereavement. PTSD-related symptoms are more frequent in bereaved family members compared to other family members. But now look at the right part of the slide that concerns only patients who died in the ICU. In white, we have family members for who we provided a lot of information, but they were not actively involved in the decision-making process. And in black, you have family members who were actively involved in the decision-making process. And of course, the second group had a very significant higher number of proportion of PTSD-related symptoms. They were all bereaved family members. But we believe that in the second group, it's the guilt. The guilt sometimes, and in our follow-up of family members, this is coming a lot. Our ability to alleviate the guilt of making a bad decision is very poor, and we need to improve this. So based on these results, we were convinced that we didn't need to avoid having the family members in the decisions. We need to prepare them and to empower them to make these decisions, and sometimes to respect their decisions not to be involved in an end-of-life decision process. And it's clear that guilt is very clearly a health outcome of bereavement, but we don't know how to capture it unless through qualitative data. And we need to ask family members what model and what relationship they want to have and what role they want to have in the decisions. This is, I believe, one of the best and one of the thinnest paper in the literature on follow-up of family members after patient death. And they have family members until 1 year after patient death. And we are not now in symptoms. We have collected symptoms of anxiety, depression, PTSD. But in this case, we are in syndromes using appropriate definitions. And you can see that 1 year after patient death, a lot of family members, most of them have major depressive disorders, general anxiety, complicated grief, panic disorder, and some of them have many disorders at the same time. So we are dealing with a population of very frail, not patients, but very frail family members. And of course, we need to move from these to interventions. To intervene, something is clear. If you do the same intervention in your ICU or in mine, it will be very different because the baseline and the standard of care is different. And in France, for example, at the time we were doing intervention, it was very easy to have a positive intervention, and our last 2 interventions were negative because everything moved and people have changed a lot, the patients, the relative, but also the doctors and nurses. So there is a clear knowledge from ICU clinicians that if they are there in the ICU, they are committed to empower family members, and they have a responsibility in providing end-of-life care by providing family members with a certain support. So the first point in my theory is that we need to consider that family members don't know. you never need to, you are never able to say, well, they know, so I'm going to move more into the decision. So each time you sit, please just take 1, 2, or maybe 20 minutes to reframe, to do the tell, ask, tell, and to ask people when was the last information they get, and to ask them what did they capture in the information, and did they understand, and then you reframe and you provide information if it was wrong. But the first point is that you need to consider that they don't know, and we are not able to consider that they know. This kind of intervention in Europe is not feasible because we don't have palliative care people that we can call. We are providing ourselves palliative care in the ICU, being held by the pain people, but sometimes other groups, but we don't have a number we can call in the ICU to be assisted in managing these patients. So this study, for example, showing that you are able to decrease ICU length of stay and having patients discharged more quickly by a palliative care intervention is not something you will see in France, for example, or in most European countries. And this one, when we used the value mnemonic that you presented earlier from Randy Curtis, with Randy, we performed a randomized control trial where family members were either included in a control group where end-of-life information and care and communication was provided as usual, with a group where there was a form. The form was the value mnemonic, and we were asking the investigators, were actually the clinicians, to provide information according to the value and to take time. We doubled the time for information and communication. We doubled the number of family conference with nurses. We doubled the time where nurses were able to voice concern and to help family members. But most importantly, we were also able to decrease the proportion of family members with anxiety, depression, and PTSD. So I'm sure that this intervention will be again positive in France now, and we are considering to redo it further. But I'm not sure that it will be positive, for example, in Seattle, where Randy Curtis has implemented this since years, and I guess in your ICUs it's quite the same. But this intervention, another one that is not proactive and is not made at a patient level, would be positive in France, and it was negative in the US. It's a customer randomized control trial with intervention to improve globally end-of-life care with local champions, with training, with feedbacks. And this intervention in France will be positive for sure. But in Seattle, the feasibility and the pilot study was providing very important information. But when Randy Curtis did the study, everything was passed already in the control group, and the control group was not the same than 2 years before. And of course, the study was negative, and they saturated at the maximum what they could do, and the intervention was negative. But the same intervention in other settings will be positive for sure. So we need to understand better our baseline things. And now, just for 4 or 5 slides, I just want to provide some different information, not about statistics and percentages, but maybe about qualitative data. When I see this paper from Ulrich that was published a long time ago in Science, and when I hear Kathleen Puntillo, I have exactly the same feeling, is that I am not able, maybe because I'm a doctor, because I'm maybe a man, and Mars and Venus, you remember Kathleen many years ago, I'm not able to think and to imagine things like this. And in this study, this nurse has the idea to compare patients and their need for analgesia and benzodiazepines according to when you open the window, if you are viewing a wall, or if you are having a view on a garden. So you are in a hospital after surgery, and you have 2 types of patients. Those who, when you open the window, you have a wall, and those when you open a window, you have a garden. And you can see that very clearly the need for analgesia is very different when you open the window, it's a garden. Because I think that they are relieved to be again in another model and with other feelings. When you open and you have a wall, and in an ICU where I worked, when you were opening, when you were looking at the window, there was a cemetery. So it was very complicated for family members. And we asked for many things, and now it's changed, but it took 15 years to change. So I'm sure that we need to think differently. And when we are intervening, there are factors that we cannot control. And some of these factors we cannot even even imagine them. When you are reviewing a paper or reading something in the literature, are you asking if the windows in this hospital are going to a wall or to a garden? It's very complicated. These are also the data when you are doing active listening and getting qualitative information. This is the paper from Judy Nelson and Kathleen Puntillo, where you are hearing people in their own words and you are trying to understand better. Actually, you are trying to get a sense, so the statistics show an association, but this is a sense. This gives a clear sense to what we observe with quantitative studies. And I think that we need now to move into more mixed methodology studies to move ahead and to be able to intervene, but to intervene on the actual targets for improvements. And this is a paper that was very helpful for many of us to understand better the struggles that family members can face when they are about to be involved in an end-of-life decision. So we know that this is complicated. This is my last slide, and I'm very clear about that. I'm doing critical care since 20 years, and there is one thing that is the clear summary of everything you have heard during this session, is that there is quite no reason to close your ICU doors, because opening the ICU doors, opening the way we are providing end-of-life care, but also a daily care, opening for family members has always been perceived as a clear sign that we have nothing to hide, that our nurses and doctors can be proud of what they do. And I think that there is now clear evidence that the level of burnout in ICUs with very strict visitation policies is very high, and it's very low in ICUs where there is an open ICU model, and not open, but where the visiting policies are very broad. So I think that this is clearly a way for us. And be reassured, when you're opening 24 hours a day, like we do, we are not informing 20 hours a day. We are opening all the time, but there is a difference between the visiting time, that is 24 hours a day, and information time. And I think that should be happy hours for family members in the ICU, where we are able to provide them with, or to try to meet their needs. Thank you so much.
Thanks very much, Elie. We have time for a couple of questions, if people would like to make their way to the mic. Let me ask, I remember well, both today and when I originally read that paper of your value intervention trial, how I was struck by what a huge effect something really fairly simple and easy to do could actually have. So I think that's an important message to get out there, that sometimes it's so complex and we can't, we feel overwhelmed, but in fact, simple things can make a big difference. I wanted to ask you, you said that you were sure this study would be positive again if you did it in France. Maybe you could just give us a little bit more context about why you think it might not be effective here. I'm not sure that's true, by the way, but and why?
You should redo it. Well, there is something I didn't say. It's simple, but we had 9 ICUs who were included in the study that never included the patient, saying, well, Elie, I can't do that. Because why? Because there were 2 things to do. The first one is that when we were sitting with the family members, you were saying, the goals of this meeting is that we are going to provide information about the imminent death. Because all the literature says, well, they want to know, and they want to know when it's going to happen. So we said, well, let's say, and we had a huge problem with the IRB. Are you going to say that the patient is going to die now? Yes. The other thing is that we were providing family members with a bereavement support leaflet, and the first sentence was, nurses and doctors just told you that your loved one is going to die. So some of the investigators said, well, I can't. I said yes, we were very happy at the beginning, but doing it, I can't do it. So I think that at that time, people needed to be convinced that we are not being harmed by providing this quite, it can be seen as cruel, but it's very helpful. Of course, we are making our best to provide information with gently, but if we are redoing this intervention today, is only because the intervention is only made in 30% of French ICUs. So it's not part of the standard of care. It didn't move from research to clinics as much as we were expecting. And if you remember 10 years ago when we published the study with a very simple leaflet, this was this. an information leaflet that we were providing at ICU admission, Bob Sebald wrote the editorial in the Blue Journal saying, well, very simple intervention, and it's very effective, and most of the very complex interventions are not effective.
Okay, well, thank you very much,
Thank you.
Philly. It's 10 o'clock. There's a scheduled break. The coffee's in the exhibit hall. And we'll reconvene at 10:30 for part 2 of this interesting session. Thanks again.